So, thank you for joining me on this session. My topic that I'm going to discuss is this whole term that has suddenly come on all over us. We never heard it 2 months back, and now everything is about this word lockdown. I want to look at what lockdown means with a public health lens and what place it has in public health and what are the very many meanings that it takes. Perhaps we should start by first unlearning something about lockdown so that we can think about it with a fresh start. When lockdowns came, it was justified in the media and in press releases by saying that India was in stage 2 of the pandemic and we were doing a lockdown to prevent ourselves from reaching stage 3. Stage 3 is a phenomena where we are going to get community transmission, and once there is community transmission, all is lost, so to speak. It's a terrible situation to be in, and if we do a lockdown, we can ensure that we are in stage 2. Now, this got picked up, it got replicated. It seems to have started from one ICMR press briefing where it was used, but it became a reality which the ministry found very difficult to let go also. Now, this idiom is actually not taken from public health. You won't find it in the textbooks of epidemiology. You won't find it in WHO. Stage 1, 2, 3 is actually taken from, many of them are clinicians and they are not even oncologists, but this is taken from cancer studies. Where when your clinical management of cancer, stage 1 is a localized disease, which you can excise and take out, no problem. Stage 2 is a very early spread, but you need a slightly wider excision, some lymph node, and you can be able to take out. Stage 3 is possibly gone beyond control. At stage 4, it is widely disseminated. Then only palliative care is possible. Now, this makes sense for cancer, but the rough equivalence that was drawn into it doesn't actually make too much sense for cancer also. But the rough equivalence that was drawn to was if you are going into stage 3 and community transmission, then you can no longer do much. It is like a cancer that has spread all over the body. There is nothing much you can do about it but mitigation, which is sort of almost looks like take care of what you can, the number of cases will happen, so the epidemic will run its course. Whereas in stage 2, you can do containment and reverse it. Now, this is not really true at all. Containment is very relevant in the later phase also. First, there is no stages. What you have is transmission. And community transmission simply means that you have a number of cases who can't quite say where they got the disease from. It doesn't matter if you can interrogate them enough till you find the possible contact, that it will still be community transmission. When you are in an earlier stage where you know your chain of transmission, then you have all those potential cases under quarantine, and most of the cases arise from within those whom you have quarantined or kept under observation, and therefore you have a sense. Whereas if it starts occurring where most of the people don't know where they got it from and it was not within your quarantine pool, then you have community transmission, and it is just an amplified phase. It is something quite natural. It doesn't mean a failure of containment. It doesn't mean that you have no options left. And it doesn't mean that you are worse off necessarily than you are before. So all these things we just need to get away from. So what then is the difference between containment and mitigation? Now, in understanding all of epidemiology, and epidemiology is not the study of epidemics, but in the study of epidemics, what you need to understand is this figure called R0 or R0, which basically means the reproductive rate, the number of people who are likely to get infected from a single case. And that number for coronavirus has been sort of cast at 2.5 with a very wide range, so we don't really know. Now, when you are doing containment, your aim is to get R naught value below 1, which still doesn't mean the elimination of the disease. It only means the disease is thus endemic. It is not an accelerating production, but depending upon the baseline, you are going to have a number of cases that are coming repetitively, which you can manage in a sort of steady state. Whereas if this thing is above R1, then you are actually having a spreading disease and accelerating incidence. And typically in a flu, it will be about 1.5. And coronavirus being more infective because the period of infectivity is longer. Because of that, because the number of days when it is infective is longer in a given patient, you will have something of a higher range. So in some sense, you are really talking of being the epidemic is going to infect most of the population. Now, the other thing about containment strategies is that in the absence of a vaccine, if you have a very high level of containment where you reduce your thing into such a low thing and trace back every case and then you can extinguish all cases, like we did with Nipah virus in Kerala, then your containment can actually lead to a reversal, to a zero case, to the elimination of diseases. But as we know in history, we have eliminated very few diseases. One of them was smallpox. But in practice, almost no other disease has been. Polio has been something. And usually these require vaccines, which build up a high degree of herd immunity so that you can cut transmission. Other diseases have not been amenable to eradication, not even leprosy, not even malaria. What you can do with them is to bring it down to a level of low endemicity. So the big problem with a lockdown is this. You can have a successful lockdown and you may have it for 3 weeks. Will it slow down transmission? It will slow down transmission. Even the poorest of lockdowns will have some impact on transmission. But eventually, the moment the lockdown is lifted, the cases will come back again. And they will accelerate again and they will mimic the pattern that you had before the lockdown happened. The only difference being that you have bought some time and that time could have been used for health sector preparedness, which is not a trivial issue. In India, we don't even think that health sector preparedness in any major way has happened, but at least it has sensitized the entire department and the people to what needs to be done and to some messages regarding social distancing that will be useful in times to come. But it's been a heavy price to pay for it. So what are the public health measures that are useful for controlling both in containment and in mitigation? Containment is only a level of control that brings the R0 below 1. And mitigation, a level of control where the R0 is above 1. But eventually, both of them have similar strategies. They are not entirely different world of strategies. So what are these strategies, the public health strategies? So R0 is a factor of the transmissibility of a disease, which depends upon the number of contacts you make, the duration of illness you have, and the virulence of the organism. If the organism undergoes no significant mutation, the trend will be for its virulence to decrease over a long period of time, but sometimes it mutates into a worsening situation. But for our given purposes, we will assume that at this point of time, we have the same virus without a mutation in either direction, greater or lesser virulence. The infectivity of the disease is about half a day to 1 day before, or even up to 3 days. Now, 3 days is stretching it. You are infective, but not in a major way. So about 1 day before the symptoms start to about 2 or 3 days after the symptoms subside. Because by then your antibodies have developed and they've knocked out the virus, so there is no virus to be shed and spread. Whereas in a flu, it's a much shorter period. So therefore, there is a larger infectivity. But the third is the number of people you come into contact So that you can decrease by the most common way is just the most severe way would be isolation at home. So if you have a severe case, you isolate at home, and as a home is not convenient or feasible or for many reasons, you would isolate in a hospital setting, in an institutional setting. So there you can ensure that there is no contact between the person and the household or the rest of the people. So isolation is the isolation of positive cases, symptomatic or asymptomatic, is your single biggest weapon. Your second is home quarantine. Again, it could be voluntary home quarantine, it could be institutional quarantine, it could be obligatory home quarantine. Depends upon the level of risk and depends upon the circumstances you do it. The difference between isolation and quarantine is that isolation is for a sick person. He's already COVID-19 positive. Whereas quarantine is for a person who has been exposed to a COVID-19 patient but is not positive. In fact, he is asymptomatic, necessarily so. And therefore, you are putting him under observation so that when he develops fever, he can be brought into quarantine immediately. And in case he develops fever, the first 2 days before he developed the symptoms, and the next 3-4 days, by the time he seeks and gets health care, you don't react to it on 1 day of fever. You react to it after 3 to 4 days of fever. So at some point, the basic distance that you are able to put on that makes a difference. So you quarantine, therefore so that is the second big strategy of public health strategy. The third is social distancing, and the first aspect of social distancing is keeping the elderly out of reach by what is called shielding. You can call it reverse quarantine, as some people have done. So it's a new term that's going around, being invented. But basically, it was shielding. So you say the elderly, people who are immunocompromised on cancer chemotherapy or on immunocompromised drugs, you take that extra mileage to make sure they don't come into contact. You just take that extra precaution. But you can use social distancing more generally by asking people to observe the certain rules which you are all by now tired of hearing. I don't think I can stand Amitabh Bachchan repeating those rules one more time. It just puts me off. And so we will skip that social distancing as something that you know. But then within that social distancing, there are a set of options which are more rigorous. These options, we can say, the closure of schools, the closure of workplaces, the closure of community sites. And when you model, most of the Western models know the level of social mixing that happens in each site and also factor in a certain potential that people will observe. So if we look at the Imperial College modeling, which is the best one available now, you will see that they have assumed that home isolation, all 70%, the entire household will be exposed, but there is a reduction of 75% of external contacts, the contacts reduced, not 100%, 75%, with a 70% compliance. So you build in the factor that some people won't comply. With voluntary home quarantine also, there's a 75% reduction in contacts with a 50% compliance. With social distancing, for example, in closure of schools and colleges, you get a certain figure of compliance, you get a certain figure of reduction of contacts. So the social mixing reduces and therefore you have a reduced spread. So in some sense, it is a more intensive form of social distancing going beyond isolation and home quarantine, which helps. Now, this, mind you, is never 100%. So the point is there is no social physical distancing measure it is still substantial. Second, though it reduces the spread, it does not stop it. And as we see under Indian conditions, it continues to increase and increase at a fair rate. It slows down the rate of increase. So the moment that the lockdown is lifted, it comes out of it. So much for the theory of lockdown and to get the sense of mitigation. Now, all these measures can be done with different admixtures. So you may say, for example, I continue to have schools, but I will decide that I will not have large sports gatherings. In my view, actually, places which occur under large meetings that under occur air-conditioned halls, like a cinema theater, are the most dangerous of the lot. I'm not even too worried about open air exposures, but at some point, each one of them have a certain risk level, and you can choose which to gather. So if you have a restaurant or a bar, many of them are air conditioned, they circulate the air inside, there is a lot of admixture, these will be at higher risk and you can reduce your possibility. But what is the heart of it? The heart of the strategy remains at all time to actively identify symptomatic cases and then test them. And if they are positive, isolate them. And if they are isolated, follow up all their contacts, place them under observation so that as and when along that chain of transmission you have any one more person positive, you isolate them immediately. So this isolation, home quarantine, social distancing is the logic that you follow, and you follow it down lots of chains of transmission. So the moment you have a severe case somewhere out there, which you did not expect, you test for COVID-19, and if it tests positive, you follow down the chain of exposure and do that. Now, in India, we got some of this right, but we sort of insisted that the known chains of contact are the only things that we will follow. We will assume that everything we are following is the only chains of transmission that exist. So, for example, Tamil Nadu keeps on going about the Tablighi, Jamaat, and that particular chain of transmission where they have picked up a lot of asymptomatic cases. And they have a lot of severe acute respiratory infection and flu-like illnesses admitted, where their testing is sometimes only half of them they test, but or they have very strict conditions before they test. In fact, they will need a CT scan and X-ray showing a pneumonia before they declare it sorry and they test, and they actually rule out the others from testing. So therefore, the other chains of transmission that exist are not picked up at all. Their answer, no, it's a waste of time. Much of it can be flu. I find this argument one of the most ridiculous. Flu is far more susceptible to social distancing and lockdown than coronavirus, than COVID-19. We just started by describing that why COVID-19 is far more infectious than the flu. So if you have social distancing that is so very well protecting you from COVID-19, it will protect you from the flu. It could be dengue, which spreads through the mosquito, but you can make that out. And at some point, you have to actually test, unless you know. So to cut a long story short, there is absolutely no excuse for any state, whether it be Tamil Nadu or even Kerala, to be not testing symptomatic people. Symptomatic, why? Asymptomatic also spread. So asymptomatic contacts, there is a case. That to primary contacts, there is a case for testing. I can live without their testing and their home quarantine. But cases which are moderate or mild, which are clearly symptomatic and worsening, need to be tested, because otherwise they are not going to stay at home and indeed should not be staying at home. They are going by public transport to healthcare facilities and seeking care in long queues and going to the pharmacy and going to the laboratory and going to the canteen. And all the time they are spreading infection. They act as super spreaders, because the people with symptoms are far more infective than the people without symptoms, and those who are progressing from mild, moderate to severe are even more so, and these are the people who are likely to be moving. I mean, you need not, when you see a case of SARI, and SARI is severe acute respiratory infection, you can assume that they were mild or moderate before they turned severe. It's like saying, it's not very profound to say after every Monday there will always be a Tuesday, and after that there will always be a Wednesday. You cannot have a severe case without having had a mild and then a moderate case. And if you haven't tested your mild and your moderate case, that is 7 days of health-seeking behavior where they were going around and once your lockdown is lifted, they'll be going around in public transport and they will be infecting people. So the core of it will remain being able to test immediately, preferably, and we've been insisting on this, by at the home. They can send a person in, they can test it. There are problems in testing it, but with the rapid antibody test, you can test even at the home. And a rapid antibody test is very reliable along with the clinical findings for diagnosing acute infection after 4 days, even more so at 7 days. And you can therefore be sure, if necessary, one can confirm later, it will be safe to say anybody with fever and cough, and sometimes cough is more common than fever, after the 4 to 7 days should be tested. And that's the core of the strategy. You need to do it before a lockdown, you need to do it after a lockdown, you need to do it during a lockdown. And in fact, if you don't do it, the lockdown makes no sense. And if you do it in some sense, like many countries have found out, like South Korea has found out, it's not really required. Now, one last question. Do you need an early lockdown? Is there some great role that you play in an early lockdown? Is there a case for a sudden lockdown? Sudden lockdown is not even public health sense. This is the shock and awe that this government likes. There is no reason, nothing would have been lost if you told everybody, please return home. We are going to lock down from Tuesday. And if you are feverish, make sure you report, and we will report when you are returning back. Please report at the local health center so that we will keep you under observation. That's also all that was needed, and nothing. Eventually, you will have to let migrants go home. If not today, tomorrow. If not tomorrow, 1 month later. If not 1 month later, 6 months later. But you will let them go home. And what difference does it make at when they go home if within that population group, the disease shall be endemic? Our predictions are that it will be endemic for 18 months. So is an early thing. In terms of the fact that it helps you give time for preparation, it is useful. But in terms of it, especially after the first thing is over, we can very well lift the lockdown. And whenever the amount of transmission crosses a point, that is the R factor becomes, say, 2.5, 3, 4. When you have an active increase in the number of cases, then and only then can you use more and add in the pool of social distancing. You can add in schools, you can add in bars, you can add in cinema theaters, and you can add in what is necessary to cut it back depending upon your social mixing parameter to the grounds that you require. You don't need to do it all the place, all the time, on all services. You just need to actually be able to isolate and test. Identify early, test early, and be able to isolate them. If that is what you are doing, you are reasonably safe. And therefore, we don't see community transmission as something that you must do in stage 1, otherwise it will become stage 3. That's all cancer and the excision of thing. Over here, doing early has a certain advantage. That advantage is over. Now it is enough if you do it in hotspots. Now, the government has introduced the concept of hotspots. That's good. That is a welcome space. It could have done it in the first time. Orissa, for example, has never had disease beyond 5 districts. Why have they locked down 25 more districts, all 30 districts? They could have waited at that few time in the early time. They could have isolated and tracked down those few chains of transmission and not lock down the rest. If they were locking down everybody, they should have tested. So at one point, they want nobody to move, nobody to stir anywhere in Orissa. But at another point, there is no community transmission. How can you reconcile this contradiction, where there is the insistence that every place is at risk for transmitting, but no place is at risk for transmission? You can't have both of that together as you think. So why did Orissa go into it all over? We don't know. It's done now. But at least now it can limit it to where not COVID-19 positive. And that was my criticism with the Kerala recommendation. But actually where there is an increase of cases. Plus, you must also do in some areas, you must have a surveillance which is testing for fevers. Because you don't know that this is the only chain of transmission. So the weakness of the strength of the current strategy which the government has announced of lock spots is good. But the weakness is, what is the database on which they are going to implement this strategy? Where is the surveillance kicking in? Where is your data? Where is the testing kicking in? If you are not testing symptomatics, how do you know you have identified all the chains of transmission there are until it is too late? If you are not identifying every and testing every severe acute respiratory infection, why are you assuming it? So that makes no sense unless you are able to actually link both together. And therefore, the problem that the government is going to face is, and I'm very worried that they are setting it up this way, is they have created a perverse incentive. It's called in our language this perverse incentive. What is the perverse incentive? The incentive is for all states to suppress not the disease but their reporting of the disease in the interest of opening up their economy. So Tamil Nadu is under pressure that Kerala, everybody is asking it, why is Kerala got so many better cases? So the chief minister has declared today that in 3 days the cases are going to go down. And the message will go all the way down to actually suppress the number of cases, because at some point, if you report cases, you can't open up, you can't get your children back home, you can't resume your duty. So there is a whole lot of pressures that build up to actually under-report, and that is what we call a perverse incentive. You have linked it up directly. What needed to have been done, you needed to have a system where then they will suddenly go into random checking. I'm not yet asking for random checking. That may be required. What we are saying is anybody with a fever of more than 3 days or a dry cough of more than 3 days, with or without a fever, or a fever with or without a cough, do test for COVID-19. The antibody test is relatively cheap, and after 4 days or 5 days of symptoms, it's rather reliable. And if it is positive, you can confirm with a PCR. You need not confirm, but if you want to, you can confirm. If it is asymptomatic and a quarantined patient whom you want to release from quarantine, you can do a PCR. An antibody is not enough. But you may need to check this out. At some point, it becomes very important that you put the testing in place. And this is the importance of this. Without that testing, you don't have the data to know that this is your only hotspot or this is your only chain of transmission. Finally, this geographic boundary of a hotspot is another bit of absurdity. It doesn't spread through the air. So in places where they have a circle drawn and you can't even take a walk there. If you look at Public Health England's recommendations, one of the things that they allow is a walk with a family member once a day. It's part, you can take a 1 hour walk outside other than going for groceries. It's part of remaining healthy. But here we have this whole, in Tamil Nadu, they call it this katakarpu, this evil that is in the miasma in the air. And therefore, around the body, around the dead thing, so the more dead he is, the more severe he is, the more the evil that flows out of that particular place. A complete wrong illustration. The next door neighbor is at no particular danger unless he comes into your house or touches a thing. But if somebody is coming from far and touching, and if you are in a market town, all the people who come to the market are important. If you are a hospital doctor, all the people who come to the hospital are important contacts. Contacts has very little to do with the physical geography. So physical distancing is important. And therefore, these circles of containment that they are drawing around a single case are quite misconceived and at some point putting a whole lot of barriers. What is the danger of all this foolishness? The danger is when it actually comes back, and it will come back after 2 to 3 months because you do not have yet adequate herd immunity. Then you would have exhausted all these means by then, and it may be more and more difficult. But ideally, if you are able to follow sound public health, you can keep this growing slowly. The herd immunity can grow slowly. You can manage the cases as and when they come. And if you can last it out till next March, then you're home and through. You can get a vaccine by then and then we are safe. Or even in 6 months, get a drug that will work and we are reasonably safe on that. But I think that basically this would be the way, and lockdowns have little role to play, and whatever damage they have done and role they have played, they have played. Lockdowns are, in public health terms, immensely costly because of the increase in hunger, starvation, and other deaths that it brings around. I have not gone into that. I think all of you know that well. Maybe we have underemphasized how much it increases other deaths. The longer you extend the lockdown, the more exponentially deaths due to other comorbidities or other causes increase. It's not just a linear increase, it's a exponential increase, much like the curves that you make for epidemics. But that I think people know, and they know the economic consequences of this lockdown, the high degrees of inequity, the burden it has on the migrant population. So I'm not been spending my time repeating these. Those are important, but I think you know them. I just wanted to make sure that you understand where lockdowns as a strategy stand in public health and the limitations of it. I'm done. You have questions? So I'll take this question from Sriram Anand. Are you hearing me? So, okay. Uh, Today in Kerala, a person tested positive after 29 days from primary contacts. It's 26 days the international flight stopped. Still, there are 5 cases from foreign returnees. What exactly will be the incubation period? Well, the simplest answer is he didn't get it from the flight. He got it from elsewhere. That's an answer we just don't consider. If I've had a flight, say 3 months back, if I get it, I don't have to invoke and say that my incubation period was longer. I have to say, okay, the flight has nothing to do with it. I got it from somewhere else. So I don't know why we have to insist that it is there. And this is my first problem. I do not think that the incubation period need to be extended. There, though, as I said, much of these are half-life probabilities. How long the virus stays in a particular surface depends upon the viral load, and you can have it after a long time also. It could have been spread to a secondary contact who was asymptomatic, and from him he got it back again. There are many possibilities. So these people who would have come, he may have come. So there are many ways in which you could have got it. So I don't think that it originally came in, but each time you get an infection, it need not be attributed to the original flight that sometime in his past he had taken. Okay, 29 days from primary contact, maybe. Of course, one thing is there. Because it's a primary contact, the primary contact can be 2 to 3 days after symptoms subsided be infective. But if his contact was 29 days back, it's unlikely. Second thing I caution you, Kerala has too rigorous a criteria for contact. You don't need that much contact. Singapore, half an hour at 6 foot distance is what they want. Hong Kong, 15 minutes. Most of the recommendations, just at 6 feet without a mask at 6 and 15 minutes is needed to define a close contact. You cross the room where he was, doesn't work. But if you are in an air conditioned room with the person for even a shorter time, then it's a primary contact. So there are rules regarding what a close contact is. And if you define it too liberally, then you will get a lot of negatives on that. Any thoughts on BCG immunity and fatality rate? I think that's a red herring. This has been invoked very often. Maybe it has something to do. But there are other countries with good BCG immunization, which have not shown this propensity. And this is a hypothesis, but we don't really know it. It rests upon the fact that we have low COVID-19, so therefore something must be protecting us. My thing is that low testing has been protecting us. And I think more than anything else on that. There is this, Deeptish comes up with the herd immunity strategy. Now, he is saying, should we let it spread, herd immunity develop? Therefore, do not postpone, do not undergo economic sabotage, but still come up with the same endpoint. Let's understand this. Herd immunity is a phenomena that happens irrespective of whether we want it, a phenomena that we must understand and therefore we can leverage, and therefore a phenomena that we can play to our advantage, but it is not a strategy. It's not something you do. But when you say that we can stop social distancing and let people walk, it would not be ethically right, because even young people will get infected. And second, it denies the possibility of a more sustained containment through testing and isolation. If you fail to test and isolate, you deny it, it spreads, some people will die, and in India, you will take a lot of deaths before it is noticed. For example, India has 50 deaths today or yesterday, let us say. I'm assuming a number. But we have some 20,000 hospitals where they could have died. Let us assume only 1,000 of them are working. So these 50 deaths distributed according, even 1,000 deaths distributed across these will not be noticed. So to say that I'm not seeing many deaths is not the way epidemics work. I've been handling many epidemics when I was in my Chattisgarh stint. I used to go in, and very often it wasn't the hospitals that were reporting it, but communities or sometimes a newspaper person. Then we found it. So I think that herd immunity is not a strategy, but yes, we know it exists and therefore we can play it to our advantage. If a lot of people turn immune, we can use them in the front line, we can use them as volunteers, and we can shield the elderly so that the infection preferentially catches on with younger people. Those things we can do. Barun, your question on IDSP and new IHIP platform is something that needs a separate session in itself. The new IHIP platform, I am not very impressed with. But my problems with most of these platforms, they don't tend to really, they are not friendly, they don't work, they call upon too much micromanagement, they are a problem. But IDSP, yes, there is no strategy without IDSP. This entire lockdown strategy is a bit of a hoax without IDSP coming in. Because in some sense, what you are doing when you say, I am not getting my information through IDSP is Integrated Disease Surveillance Program. Then it means that you are getting it from a chain of flow of information that is controlled by the secretary and the political apparatus. Therefore, it doesn't have the necessary autonomy to be reliable. And it is not, in fact, reliable for that reason. But IDSP reports the S form, the suspected cases, the presumptive cases, and the laboratory cases. And by triangulating this information across different sources and points, you can get a much better version of the truth. And therefore, in the long term, because the disease will be around, at some point your district collectors will lose interest in controlling and catching and suspending. You will need the IDSP to work. And so this is one of the areas which we have underplayed in our health systems preparedness. We have not talked enough about strengthening IDSP. There are problems there that we will need to attend to. Okay. Will active testing in the hotspot areas be of any help, keeping in mind the low cost involved? I think our focus should be on testing symptomatics. When you're saying we will test asymptomatics in hotspots, I'm not very convinced. But it can be done, no harm. Iceland does it because it tests everybody, but we're not really Iceland. I would say, other than symptomatics, which we are not testing at all or not testing enough, we can test primary contacts, not even secondary contacts. We can test primary contacts within an area or even potential contacts, but we should not extend testing beyond it, just increase our test negativity rate and confuse us. I think we should focus on this. It's like malaria surveillance we do, no? And Varun, remember, our malaria surveillance is much better than our ID surveillance. What is our criteria? There is a standard of testing. We have to do 10% of the population, and we have to do fever cases. All these fever cases we do using a rapid diagnostic test. And if we have done 10%, then we look at positivity and we say, okay, so much is positive per 1,000 cases. If more than 2 per is positive, then you have an endemic. If it is rising, epidemic. But if you have not tested enough cases, if this testing standard is not in place, then you do not rely on your positivity. Unfortunately, for IDSP, we have not, for COVID-19, established a standard of testing. What is the minimum testing you should do before you rely on your positivity as being truthful? That has to be necessary. Yes, Anusha, we can extend the same logic to the Northeast. Most of Northeast has been unnecessarily suffering under I think they should, however, introduce disease surveillance. They should introduce testing for symptomatics linked to the flu surveillance program. Remember what I said about the flu? If you have done good social distancing, your flu should have also gone down. So if you are seeing flu, then maybe it is COVID-19. I'm not saying it is COVID-19. And therefore, there should be testing of symptomatics in all the IDSP sites, all, which means really your P forms and your L forms should be really, P is the presumptive and L is the laboratory, should be inspected. But beyond that, you don't need a lockdown. Lockdown has been terribly wasteful and punishing for no good purpose over there because the disease is about to enter now. It's not made its entry, and you lock down when there is no thief inside, and then when you're opening the door when they are coming in. So it's as silly as that. I'm not a great favorite of hydroxychloroquine. I think we should send it to Trump and we should keep enough for ourselves in case it's useful and we need it for a lot of other purposes. But I don't think that the studies are very convincing. The first study from France was actually a Sanofi study, and Sanofi is the main manufacturer internationally. And though we have the main API coming from us, and the other studies are all uncontrolled studies, and this day we know that. But we never know. At some point, maybe it will be responding. But the concern I have, and I heard this from TIS, is that Dharavi is being used as an experimental ground because it's a slum population without proper informed consent, which will be dangerous because you may lessen the rest of the social distancing to be taken on board. So that's a different issue. Do you think WHO has delayed in responding to COVID situation in advising countries? If you think they have not done enough to expose India's poor testing, then you can't. It is the same standard that you have to apply to China. It's a very back of the backhanded experiment. Let me put it positively. In China, they did what they can do within a diplomatic protocol. They kept telling China what they have done, and they kept telling them what they should do. They kept saying you should test, you should isolate, you should do this, you should do more. But on the public stage, they said that China is doing a good job, and they haven't overstated that, right? They have just stated it. Maybe they overstated it is one challenge, but otherwise, whatever they have said. In India too, they are saying India has done a good job with the lockdown, but they should be testing more and isolating more. These are the main strategies. But do you really think that's what they are communicating? No, they are communicating that you are missing the main strategy, but they can't do that publicly and stay over here. So there is a limit to which they can, in the public domain, criticize a sovereign state for not doing what they want it to do. This is not like the International Atomic Energy Commission that can go in and cross check and verify whether what you're saying is the truth or not the truth. The WHO has no such powers. It's something that cannot, it has to have the necessary space from the local government, and it will have to be done that. Why, even in the state government, do you think they will allow you to go and look at the hospitals and find out the number of cases which are positive there? Do they allow our own journalists? So it's not much chance that they will allow, and this is, I'm talking about India and Tamil Nadu and Maharashtra. So if that's the level of access that we have and WHO has here, why would we expect China to have? Within this limitation, they did what they could do, and I think they've done a good job. They've been looking at a number of issues on that. I think there were a lot of questions, so I'm not able to organize within them. Unfortunately, Sanjay says no country has preparedness in spite of long history of epidemics and pandemics in the world. Testing and vaccine are not in place. Listen, this is a new virus. So the tests and the vaccines have to be created. But look at what Iceland and South Korea did. The moment they heard of a pandemic which is there in the Wuhan and that is going to lockdown, they first reached out to their indigenous factories which can make it, gave them all the technology they required, gave them all the virus samples they required, and said, start manufacturing tests. So that by the time the epidemic hit them, they had actually started indigenous in-country manufacture. Now that is the key. An indigenous technological capacity, not only to create the product, but to scale up its manufacture to our needs. And that we have really failed on doing. So it's like the Karna's curse. No, at the moment of your need, India, the pharmacy of the third world, found itself not able to provide itself with the tests and the vaccine. Vaccine will take a longer time because you have to test on normal people, then expose them to infection, and then see that they are not infected. And since you're giving normal people, you have to have a very high standard of safety. So you otherwise will create, for example, disease in all the people you vaccinate. So you have it takes its time. You can't do it with a new thing. There is, however, the concept, and this was told to me by the then WHO representative in China, who is now India's representative, that we could have done a library, a catalog of coronaviruses in bats. Bats have a lot of coronaviruses, and they don't come only because you eat bats, which mostly they don't do. They came in Kerala from bats, and they didn't come because we eat bats, but bats eat fruits that we also eat. But these mammals tend to have a close association with these viruses, and we need a virus profile and some broader spectrum vaccines against them. So there is something to be done, but I would not really think. But yet there is a degree of unpreparedness. Public hospitals need a surge capacity that we do not maintain. Privatization has been a great problem in our response. So there has been a huge amount of problems at why we are not able to, but that has nothing to do with just pandemic management. It is how health systems preparedness in terms of surge capacity, in terms of IDSP, and in terms of self-reliance in technologies that is critical to it. Is there any credibility to the pooled testing strategy? Yes, there is. In a place like Northeast, when I am doing surveillance, when the overall incidence is low, a pooled strategy will save me time. Because I expect out of 500 cases, there will be only one positive. So I do 4 pools of 100, then one of them is positive, then I go down and locate which one it is. But this is not going to really work if you have a much higher number of cases. but it is a very good technique for surveillance because you do need to do a substantial number of tests before you are able to actually be sure in a surveillance protocol that you don't have positive. So I don't see pooled testing as useful in an epidemic, but I see it as invaluable in a surveillance technique. Unfortunately, all these guys discussing it aren't saying that. So perhaps you can start. How, according to you, Maharashtra government is dealing with the containment? Pass. It's a judgmental question. Not going to take that. Comment on pool testing. I've already done that. I hope that was satisfactory. Reinfection in cured patients being reported. This is worrying. But I don't think we should make too much of it for two reasons. First, we don't know whether it is reinfection or relapse. Our first hypothesis should be it's relapse. Second, we don't know whether it are problems on the testing viability, false negatives, false positives, which are still very high. The China test had false sensitivity of only 70%, and JP in one of his videos says it was only 50%. Even now, many of the Chinese tests across the world are not passing quality because of low sensitivities. So therefore, we could have missed it and it's not a relapse. But a third possibility is there that, one or two cases, because all of these, as I said, are Gaussian curves, there will be outlier cases. We should not change our protocols because of outliers. So at this point of time, we will continue to assume that a person cured is going to be immune for life to this particular strain of virus, at least for a good 3 to 4 years. And therefore, we need not take on this reinfection too seriously at this point. But you keep these caveats that I said in mind. How long will this linger post-endemic? So, to be truthful, I don't know. But to be one of these experts that come across on the TV and comment on everything, let me say 18 months. Because after 18 months, you won't remember what I said now. But I don't really know. But let me put it this way. Less than 6 months is not likely. Beyond that, it depends upon the spread. It will spread into Northeast. It will spread into the remaining districts of Orissa. And whether we are able to contain it as and when it spreads, or whether we will let it go into an epidemic phase and then only contain it, will remain to be seen. I may be missing some questions, so you can perhaps send it to me. Okay. Contain spread in crowded areas where the people cannot be controlled, like in Dharavi. So I think we should look at social distancing not as one catch-all phrase. We should start saying specific things within that which people should observe and not observe. So I think we should think of isolation and quarantine in comfortable places outside their area, first thing, so that the isolation, the infected people are removed from the group. I don't think we should prevent normal activity and going to work and coming back, etc., because that may actually decrowd the area. By the way, even in the models that the Imperial College did, when they talked of closure of schools or even community spaces, they built in a factor where household contacts, household level contacts increase. There's a 25% increase in household spread when community spread or school spread is schools are closed. Now that sort of spread, when workplaces are closed and community sites are closed, in Dharavi the spread should actually increase in these models. Okay, so in some sense, what you need to do is to say we don't do social distancing as such. We do have some elements of it, like washing your hands. Some of the high risk elements of it we will limit, but the rest of it is actually pretty useless, and we will just stick to isolation and quarantine. But look for community managed isolation and quarantine sites by people who are friendly to them, who are doing it as a way of decluttering the place rather than doing it by, it shall not be done by, it shall be done by sensitized NGOs guiding them, but by community representatives who are comfortable with them. So if we can do that, that would really help in Dharavi. We need both, therefore. We need community managed isolation and quarantine sites and a giving up of most elements of social distancing except hand washing, maybe masks. For those who are unwell, definitely, but I'm not a great one for masks. Poor quality of testing kits from China, yes. The problem with antibody tests is validation is a problem. Poor quality in terms of negatives and positives is a problem. In fact, some of the delay that are coming to China is because for their own reputation, they are imposing quality tests. But I believe some of the kits that have arrived to India have not passed quality tests. The RT-PCR test is somewhat better and easier to build in quality than the antibody tests. But even the PCR tests are failing quality. So there is a problem with this quality issue. Can a cured person be still a carrier of the disease? Unlikely, very unlikely, especially after 3 days. But the protocol today requires that they are tested again, and there must be a negative test before they are discharged from isolation or thing. So there must be it stands to reason that the antibody that killed the virus in the bloodstream will also kill it from transmission. However, there is some reason to believe that 1 or 2 days after they can be infective, but again, too much is being made of it. I would generally say that if they test negative before discharge, that's good enough. At some point, they are cured and there will therefore be not carriers of the disease. They are community assets. I think this is a very strong message that we must carry. Cured people are a community asset. They can be your front line, your barrier. They can manage your community quarantine centers. They can manage your isolation centers. They can destigmatize. They should be given a hero's welcome as they did in one place. And they should be used on the front lines rather than being stigmatized and shut off. So that would actually help reduce the stigma in this whole process. What are your views on training and preparing Ayush doctors? Yes, they can play a major part in which care they can be, but you're using them as more hands rather than Ayush skills. As long as you're clear on that, we can use that. You have Irtika Ali has asked the question about elderly who are living alone and have to step out to buy the basic material. I think here community solidarity has a very big role to play. The community must actually reach out and say that, look, we'll take care of you. And at some point, if the community doesn't have the relationship and elderly staying alone seldom are grumpy people who may not have, then you must have appointed daycare providers, other or especially the ashas who must have this particular role to play. So there must be a care provider because they are sick and they should not be. For them, isolation is a must. The worst case scenario, you must actually move them, and this is to an isolation facility where they are given the care that they need to get. Okay, so this is important. And I would say that isolation hospitals must be run with community support on this. So are there any questions that I have missed? Growing stigma and political metaphors of the disease. So I think this is a huge problem that we are facing. We are facing an unprecedented stigmatization. Worse than I'm now able to say that worse than what we saw in HIV. In HIV, we had no stigma against doctors. We did not see any problems with burial and cremation. We did not see hostile attacks, except on very select groups. Here we are seeing it. So this is unprecedented. We have spread the stigma. The government has spread stigma through the subtext of its messages, which has projected social distancing as 100% cure-all. Therefore, anybody who is falling ill either to be blamed himself, feel guilty and take the blame, or he has to blame some other person. By also indicating that a particular community needs to be blamed for most of the cases, they not only isolated that community, they sent a signal out to other communities to be in denial of disease in their community. Because if they admit to having a disease in their community, it means that they have also got delegated to the same state as the stigmatized community. So denial occurs much faster, and therefore combined with fear and panic that there is nothing. So why you keep saying there is nothing that can be done except social distancing? And therefore the doctor is not seen as somebody who can help you, but somebody who can bring disease to you. This is bizarre logic that we have spread in the. But if you see it, it's the clear subtext of our message. And this subtext, which has been with a very, very communicative and powerful Prime Minister, has been able to has such a subtext that at some point people actually, I'm afraid, at least I feel scared when he is going to speak next. In some sense, you don't know what is the next thing that's going to come, what is kya abhi aa jayega. You, at some point, there is the subtext of fear that is there in his message. This whole idiom of the Lakshman Rekha, is an idiom that if you cross, then everything goes, then all is lost sort of idiom. But social distancing is not like that. The proportion of the probability of infection lowers, but it never reaches zero. And that message has been completely lost. And therefore, a huge degree of blame and this attaches to it. Receiving disinfection of groceries, can fruit salads be eaten? Well, let me put it this way. There is a lot of information on this. One bad information, I don't know why I'm starting with that, is refrigeration per se does not eliminate the virus. So don't rule that out. But there is almost nothing that is not eliminated by a good water wash, and a soap and water wash is 100%. Now, on groceries, especially that are perishable, the simplest measure is to just leave it around for 8 to 10 hours and then use it. Just leave it in the bag that it is on, and it will be after 8 to 10 hours. On plastic, it can continue for 2 days. It can remain viable, and metal for 2 to 3 days. But really, the infectivity lower. So even if it is viable in an in vitro situation, it's not likely to be viable. But plastic and metal surfaces, the soap and water is good. But really, for the rest of it, just leave it there. In the sun, it will not even last 3 to 4 years. This disinfection of the road is such a waste of time because the sun does a better job. And at some point of time, the disinfection you do, it makes no difference. The next person who walks around will have the illness on that. So I don't think this. Can they be eaten? After they are washed, they can be eaten. They're excellent. I think they should be. I don't think there is any fruit or vegetable or meat or this that should not be eaten. It's very interesting. In Iran, the advice is to stay at home and eat a lot of meat. Over here, the advice is stay at home and eat a lot of vegetables. I suppose both work equally. Okay. I have. We have enough. Don't worry about the HCQ. I think our manufacturing scale. I listened to what the Indian manufacturers were saying. They're confident about it. If they are making a killing and exporting it. Also, we don't want the US to say that it will not export test kits to us. So we shouldn't be in a position of saying we won't be exporting hydroxychloroquine to them. But remember, China, we are dependent upon a few countries for these goods, and therefore we shouldn't act high and mighty where we have the ability to this. And our needs are taken care of, so I don't think that we should be really worried about it. And hydroxychloroquine export in return for importing of test kits, quite a deal. Should go for it. Okay. I'm worried Trump will limit imports of test kits, and on etc. there will be a problem unless they can take the China of the market, which is really what the whole about is. Why the US defunding WHO, because this game far from being the accuser, the China from far from being the accused is returning somewhat triumphant. Not only have they controlled it, the world is dependent upon Chinese PPEs. The world is dependent upon Chinese testing kits. Out of the 33 suppliers, we have placed orders for antibody testing kits. 30 are from China, 2 from South Korea, and 1 from Israel. Of our RCR kits, most of them are again from China. Of our PPE, there are some imported components that only China makes, no other provider in the world. And at some point, China has sent down flights of goods donating in goodwill in a major way, whereas the US is looking rather silly with 6 lakh cases and a huge number of deaths. Now they are feeling China can't have these figures. Those figures must have been faked. Well. Okay. This pandemic as a great opportunity to strengthen public health, a great leveler. I'm becoming a bit cautious about it. In the beginning, in Spain, for example, private sector hospitals were brought under public authority. We felt it was good. India was also moving to identify private sector hospitals that can be made COVID-19 hospitals and brought under public authority. But what's happening now? Now they are finding that they are not able to clinch the deal with the private sector hospital, and they are shutting down their main tertiary care sites like the Mekahara Hospital in Chattisgarh or the KEM in Bombay, or at least locking away parts of its capacity and giving it to COVID, displacing those patients who either have nowhere to go or land up going to the private sector. So the public sector as the residual care, providing care for those who cannot go to private sector and for those needs that the private sector does not handle, is the form in which COVID-19 is coming to the public sector. So is it making a case for the public sector? I think it all depends upon whether we make the case for it. Left to itself, it can actually work for privatization. And this is something I'm seeing for the last 3 to 4 days, and I'm getting worried about it myself. The Kerala government's Dhyaneshwar has asked, you comment on Kerala government report on how to lift lockdown. Do other states follow that? I think the Kerala government's staggering and facing of the return of economic activity and essential services is very well done. I think the central government has learned from it, and other states can also learn from it. The criteria for categorizing areas as deserving lockdown, deserving caution are not done. I'm not very happy with it. It's fixed the criteria at 1 COVID positive case, which means the perverse incentive to actually lower reports places, and it's far too low set a threshold. At some point, if essential services enter, they don't enter on a magic carpet. They will come with truck drivers, they will come with truck helpers, they will come with wage labor, and at some point, disease will come. So every time you have a single case, it makes no sense to shut it all down. So in some sense, you have to go back to the notion of endemic disease. But what is really a problem in the Kerala instance is that they are not testing symptomatics and even SARI cases in all districts. So they are along the chains of transmission as they are known. They have done a great job. They may have done such a thorough job that they will have eliminated all existing chains of transmission, which is in contrast to what others can do, because they have many other forces that have helped them on the Nipah virus experience, their ARDHAM program, their palliative program, which they have all leveraged. There are strengths that other states don't have. But even in Kerala, the disease may come back in different pockets through asymptomatic carriers or other carriers and grow in clusters undetected unless they test symptomatics at all districts to a minimum standard of testing. I don't see that yet in Kerala. So I am frightened for Kerala that they may celebrate too early. They need to be cautious. And Kerala should be a bit more worried about the second peak, if you ask me. Remember that we are all expecting a second peak, a July to September peak. And at some point, Kerala needs to be cautious and keep its. So I don't see them strengthening surveillance. It's still a IAS officer, special team driven surveillance, which is not a very good one when you have linked it to economic gain and political rewards. Okay. So are we done? I think we should close now. Ah, what are the measures and approach we need to take in order to meet the increasing demand for medical infrastructure on per day basis to control it? I'm not sure what you mean, Vedant. I think that infrastructure, we need to actually ensure that the public sector has not only adequate beds, but it has a surge capacity, which means that the design of public health infrastructure should always provide for a 25 to 30%, if not higher, excess. This excess is usually provided by big corridors, wide corridors that can be converted to beds by using certain areas as community spaces, which can be converted to wards, and by having some redundancy in ventilators and in nurses. Normally, in nursing staff, there is a 30% leave vacancy that has to be put on place. That's why when you cancel leaves, you will get that much, because normally nurses need that because they have young children. They also have a greater to other illnesses. You need that. So, this sort of redundancy within the public system is very important to create. Now, if you design your system to be minimalist, where you just do whatever is minimum necessary and leave the rest to the public sector or to the private sector, then you are overwhelmed. Not only with this, with any disaster. When there were the poisoning of school children in Bihar, what did you see? You saw a lot of children being rushed for ventilation. They made a story later of the A&Ms not being there, doctors not. It wasn't true at all. There was, in fact, an A&M training camp happening. But faced with the requirement of ventilation, which is a maximal effect, your minimalist system on Bihar could not do anything. So you needed that sort of resurgence, this sort of surge capacity in all these places. You need a certain redundancy. And that is something that we have not learned to plan for. In fact, we are sub-planning. Will extending lockdown be of no? It will be harmful. Extending lockdown is already harmful. Non-COVID 19 diseases are rising sharply. No further gains are there over gains of isolation and thing. You need to controlled way. You need to start special trains to take back migrants to go home. You need to check them, give them a health checkup, as the migrants themselves are suggesting. Give them a health checkup and reach them back home. Let them home quarantine for 14 days. The disease will reach there eventually. Let it reach there under controlled conditions. So you need to actually arrange separate. We can arrange flights to bring back people from Wuhan. I don't see why we can't arrange trains to send back people to Bihar and UP. It's far cheaper. And they'll possibly even pay their train fare. But in some sense, you can actually send it back. So, in some sense, I don't see the whole merits of these things on keeping this lockdown extended. This particular extension is hugely problematic. I don't know why we are saying, Uma, that we don't have institutional mechanisms for integrating disaster management and epidemics. I think the IDSP had a flu influenza surveillance system. It had an epidemic. On February 23rd, this system stopped reporting. You must ask yourself what happened in February 23rd. February 23rd is when the epidemic gets serious business. It stops reporting, and the reporting gets taken over into a different channel. It's not a great system. It's got a lot of flaws. It's reports, but potentially the structure is there. So there is a need to build upon that structure, because eventually you will need that. You call it by any name, you will need that. Okay, let me take this as the last question. Are mutations possible? Okay, uh, this is speculation. Mutations are, of course, possible. So your answer to your question is yes. Will mutations occur? Now let's know this. For whatever reason, over time, there's a decay that happens in the genetic material over a time that varies widely. They lose a certain amount of their virulence. Okay, more and more mutations make missense of it, and therefore they lose virulence. So normally mutations are okay. They happen, but they do not make it necessarily more virulent. They may make it less virulent, but they are minor mutations. Largely, they remain the same. So there will be some process, and that you're already seeing. You're already seeing different strains have developed. They behave much like the original strain, but there are differences between them. We are worried about two processes. We are worried about, suppose there are some viruses that are preferentially affecting the younger population. Then when the disease goes a circle around and comes back, the people, right now it has affected older population and they have some immunity. The younger population have been protected, and to the extent that herd immunity has not developed, those sections may now, you are protected very well now, but when they come back, they can get hit with a worse virus. This is a danger. We will live with that danger. We will hope that a vaccine comes before the mutation comes, because the vaccine will be broad based, and therefore it will take care of this virus and a mutant virus. Usually, vaccines are built that way. So let's hope we have that much time for us to manage. Thank you. We'll close now. Thank you.